topic of the lecture is obstructive pulmonary diseases. Before we get into obstructive pulmonary diseases, we have to know what are the obstructive pulmonary diseases? What are the restrictive pulmonary diseases? How do we differentiate them? So we differentiate them on the basis of pulmonary function testing. So in case you have forgotten about pulmonary function test, I have to revise them for you so that you might get the better idea of obstructive and restrictive pulmonary diseases. Let's get into that. First of all, I'm going to tell you about restrictive pulmonary diseases. What does the word restriction means? It means there's some blockage, there's some restriction to which air cannot move in. Inspiration is not happening because of some restriction, some blockage. And all the pulmonary function tests that you will perform, you will get the following readings. Don't worry, I'm going to explain them for you. First of all, I'm going to tell you what total lung capacity is. Total lung capacity is the maximum amount of air that you can inspire after the tidal volume. You're breathing normally, it's called silent breathing. Then you decide that I'm going to take all the air in. Then you go like, but there's a point after which you cannot inspire. That's called total lung capacity. At that capacity, lung is holding 7 liters of air. Lungs are holding 7 liters of air. It cannot exceed that. So this is called total lung capacity. First of all, I'm going to tell you about the terms and I'm going to tell you how are they being affected in this condition. Then comes the residual volume. Residual volume is the volume of the air that is always left at the end of forced expiration. Like I want to expire all the air. So I'll go like, but some air is always there. Why that air is there? I want to expire it. The point of having that air inside is for not letting the alveoli collapse. If all the air is out, the alveoli will collapse, all the respiratory system will collapse, the person will die. Therefore, there's always some residual air inside. So what will happen to residual volume? I'll tell you later. So this is residual volume. The volume of the air that is present inside the lungs after the forced expiration. Then comes FEV1. Before FEV1, I would like to tell you about FVC, forced vital capacity. Forced vital capacity is the amount of air that you can expire when you go for forced expiration. That if I want to go for forced expiration, I'll take all the air in and then expire all the air out. That's forced vital capacity. It's just like I'm going to tell you that it's your birthday, it's your 4th birthday, you have to blow out all the candles in one try. What are you going to do? You're going to take all the air in, then you're going to try to blow all those candles, but it's not possible in some cases if you're 50 or 60, but in some cases it does happen. So that whole air which comes out of your mouth in the case of forced expiration, that you're trying to expire every bit of that air inside of your lungs, that's called forced vital capacity. What is FEV1? Forced expiratory volume 1, meaning forced expiratory volume in 1 second. So FEV1 is actually a part of FVC that we already talked about, forced vital capacity. But it's the amount of air that comes out of your mouth in the first 1 second. And you will be amazed to know that 1 second contains 80 to 90% of the whole air expired. Meaning maximum FVC can be 5 liter. Out of them 5 liter, 4 liter comes out in the first second. So FEV1 is actually 4. And all those 4 or 5 seconds afterwards contain only 1 liter. Afterwards, we're going to talk about restrictive pulmonary disease. So how does a restrictive pulmonary disease is going to impact on all of these tests? Let's do it one by one. So we already discussed what a restrictive pulmonary disease is. There's a restriction to the airflow, to the air inflow. So what will happen to total lung capacity? It will decrease. The capacity is compromised because something is restricting the lungs to get the maximum amount of air. So total lung capacity will decrease. What will happen to residual volumes? Residual volume will definitely decrease because you're not taking enough air for the basic amount of residual volume to be there. So it will decrease. What will happen to FVC, forced vital capacity? The amount of air that you can blow with forced expiration. It will decrease. Why will it decrease? Because due to restriction, you're not taking enough air inside your lungs to expirate that much. That's like normal value. You cannot even reach that normal value because you're not taking that much air inside your lungs. For example, before that, if it was 5 liter, that forced vital capacity was 5 liter. Now it's 4 because you took only that much amount of air. So it's going to reduce. What will happen to FEV1? FEV1 may decrease, but in some cases it stays normal. Because in first second, all of that air is going to go out. Maybe in some cases, in minute cases, it stays normal, but mostly it also decreases up to some extent. Not much extent, but it is also going to decrease in some extent. So all of this will happen. So what will happen to FEV1 or FVC ratio? We decide the progress of a lung on the basis of FEV1 or FVC ratio. What will happen to it here in a restrictive pulmonary disease? It's going to increase. Yes, it's going to increase because FEV1 is either normal or slightly reduced. On the other hand, FVC is markedly reduced. So this will lead to increased FEV1 or FVC ratio. Now let's get on to obstructive pulmonary disease. What do you think about obstruction? What will be the obstruction? It can be anything. It can be anything which is not letting the air go out of your mouth, leave the system. In restrictive pulmonary disease, there was a restriction of air coming in. In obstructive pulmonary disease, there is obstruction of air going out. So these are opposites. So when we will perform pulmonary function tests, what do you think will be the results are? What do you think the results are going to be? Let's see. FVC, forced vital capacity. Will it increase or decrease? It will either stay normal or decrease. Why? If obstruction is significant, it won't let that much air escape. It won't let all of the air escape. So that's why it's going to stay in normal or decrease. But FEV1, which we talked about, it's going to be markedly reduced. It's going to be markedly reduced. Why? There's an obstruction. Maybe obstruction is that serious that in the first second, you cannot even blow properly. You cannot even let go of air properly. So FEV1 is going to reduce markedly. While on the other hand, FVC, as I told you, FVC is going to be normal or mildly reduced because all of that air is going to come out eventually when you push it out. But in some cases, it's also reduced when the obstruction is so prominent and so massive that it won't let all the air go out. What will happen to FEV1 or FVC ratio? It will decrease. Why will it decrease? Because FEV1 is reduced markedly and FVC is either normal or reduced. So this will lead to decreased FEV1 or FVC ratio. For example, let me give you an example. Normally, FEV1 is 4 liter, for example, and forced vital capacity is 5 liter. So 4 by 5, we will get 80%, 80 to 85% of FEV1 or FVC ratio. Now let's get on to this example. Let's put numbers into it to understand it better. In this case, FEV1 is markedly reduced. That means that maybe it was 4 liter, now it's 2 liters only, or 2.5 liters. For our convenience, let's assume it's going to be 2 liters. And that FVC, which was 5 liter, is now mildly reduced to 4 liters. So it's 2 by 4. It's going to be 50%, which was supposed to be 80 to 85%. In restrictive disease, it increased, but in obstructive disease, it decreased markedly. So total lung capacity, it can either be normal or increased. When will it be normal? When obstruction is not that significant, it's going to be normal. When will it increased? When will it be increased? When this obstruction is significant, that air is trapped, total lung capacity has increased. Residual volume, you can just guess it. You don't even have to look at it. Because of obstruction, there's some volume that will stay due to that obstruction, and there was other volume which was supposed to stay. So the volume which was supposed to stay plus the volume which has to stay because of obstruction adds up, and the residual volume will increase. Now, after getting a complete follow through of the pulmonary function testing and how we differentiate the obstructive pulmonary diseases from restrictive pulmonary diseases, we are going to start the obstructive pulmonary diseases. Once again, I have to let you know that in obstructive pulmonary diseases, there's going to be an obstruction. There's going to be something that won't let the air out. It can be minute, it can be major. As we will go along the diseases, as we will go along the pathologies, I'll tell you how to deal with them, how those pathologies are occurring, how it's not letting the air go, how it's trapping the air, how the air is being trapped. So let's start with emphysema. Whenever you hear the word emphysema, one thing must get to your mind, and that thing is destruction of alveolar sac. Yes, destruction of alveolar sac is called emphysema. This is the normal alveoli. Look at it. Every cell is very much differentiated. You can see them, it's working, everything is fine. And then comes emphysema. Alveolar sacs are being torn apart. They're being destroyed. They're being destroyed, all of it. It's emphysema. So first of all, we have to know what are the types of emphysema. Well, it's going to be 4 types, obviously. Just guess it. First of all, it's going to be distal SNR or paraseptal emphysema. Let me tell you one thing, very basic thing, which I forgot to tell you, that what is SNR? You might be hearing this word very often in this whole lecture. That what is SNR? SNR is actually the functional unit of respiration. It contains terminal bronchioles. Let me revise it for you. Bronchus converted into bronchioles, which converted into terminal bronchioles, and then came the alveolar sac. Those terminal bronchioles and those alveolar sacs and alveoli are collectively called SNR. And this is where respiratory epithelium is present, and this is where the whole gases exchange is occurring. So when emphysema is going to happen, it's going to destroy the respiratory epitheliums. It's going to destroy those basic areas of respiration where the whole gas exchange is being taken part. So first of all, we have to know that whether, so we decide the types of emphysema on the basis of its destruction. First of all, if it's distal SNR or paraseptal, it's going to affect only distal part of SNR. Meaning it's going to affect only the alveoli. It's not going to affect the terminal bronchiole. So that's why it's called distal SNR. The distal part of SNR is being destroyed due to emphysema. On the other hand, terminal part is all right. Then we came on to pan-SNR or pan-lobular. Pan-SNR meaning that the destruction lies within the terminal bronchiole. Destruction lies within the terminal bronchiole, and it's also affecting the alveoli. So all of the SNR is being affected. Alveoli and the terminal bronchioles. That's why it's called pan-SNR, the whole SNR. Then comes centrilobular SNR or centri SNR or proximal SNR. This is a type of emphysema which leads to the destruction of this, not alveoli, but only respiratory bronchioles, only terminal bronchioles. They are being affected. Alveoli are totally fine. This is called centrilobular or centri-acinar or proximal acinar. Then we go on to irregular. There's no regulation at all. It's affecting everything. We see it in fibrosis of the lungs. Let's get on to the pathogenesis of this whole system. What will happen? First of all, if you're a smoker, I'm sorry, but everything will be reading here, everything will be going through, will be affected by smoking. Will have a part with smoking. So before I go into the details of pathogenesis of this whole system, let me tell you two things. At the level of alveoli, there's a macrophage present. It's called alveolar macrophage. That alveolar macrophage has a function of destroying anything that gets to that level. Mostly in 99% cases, nothing gets to that part because it's so tiny. But in some cases, some things get there. And what's alveolar macrophage is going to do? It's going to destroy it. It's going to eat it. But in the process of that, in the process of eating that, in the process of destroying that, it's going to produce protease. That protease, the chemical protease, is very dangerous for the epitheliums, for the alveoli. It's going to destroy them. But in nature, there's another chemical present which is called antiprotease, which produces alpha-1 antitrypsin, which will immediately come in and neutralize the protease. And that's how no damage will happen. This is a physiological process. So what will happen in a pathological process? Pathological process will happen if this balance between protease and antiprotease is affected somehow. There are two possibilities of that being affected. Either protease is in large amount and antiprotease is in small amount. So it's trying to neutralize it, but the protease activity is too much to control. And in some cases, protease is normal, but there's no antiprotease. That happens in some congenital disorders that we're going to talk about. So let's get into it. How the pathogenesis of emphysema works. First of all, almost nothing, I should not say nothing, almost nothing gets to alveolar level. Not any foreign body at least. But smokers break the rule. They inhale the smoke up to the alveolar level. What will happen at the alveolar level? As you can see, these are the cells present in the alveoli. Inhalation of particles and vapors will take place. Here presents the alveolar macrophages, which will take it in immediately. These alveolar macrophages and PMNS phagocyte star particles, they will take it in immediately and they will produce what? Protease, which we talked about. I would like to tell you that here lies the type 1 pneumocyte and type 2 pneumocyte. One thing that's very important is type 2 pneumocytes. Type 2 pneumocytes are the cells which are required for regeneration. If anything is damaged, you're going to go for type 2 pneumocytes. They are going to help you. So it's very important to memorize that type 2 pneumocytes are the ones that does the healing. So all of this happened. Macrophages took them in. What happened next? Those cigarette smoke and O2 and hydrogen peroxide, they went on and inactivated alpha-1 antitrypsin, which is elastase inhibitor. They went on and inactivated it. When they inactivated it, protease activity will rise up, but antiprotease activity is gone. Mostly this happens in some disorders, congenital inherited disorders. So let me show you what happened there on the phagocyte level. That protease activity happened. Protease containing granules release the protease because there is no alpha antitrypsin present here because of some problem, because of some hereditary problem, alpha-1 antitrypsin deficiency is happening, or this reaction inactivated it. So protease, what protease is going to do? it's going to destroy the epithelium. It's going to destroy the alveolar valve and elastic tissue. Uncontrolled proteolysis will happen, and this will destroy the alveolar valve and the elastic tissue. When the elastic tissue will be lost, what will happen? That ability of recoiling, that elastic ability is gone. Now all those alveolar walls which were very elastic and they recoiled won't recoil. For example, if first they were balloons and the air was pushed into them, and when they were given little space, all the air rushed out and the balloon went away. But now all of the elasticity is gone. Now they're just shopping bags. What if I ask you to fill the air in a shopping bag, and then would it react the same way as the balloon did? All the air will rush out in a massive way? No, because there's too much space to leave. It won't react the same way. It has no elasticity, which that balloon had. So due to this uncontrolled proteolysis, that elasticity of the wall is going. This will lead to destruction of the alveolar valves and destruction of the alveoli at the end. Destruction of the elastic tissue will happen. So there were two reasons I told you about, that either it can be inactivated or there's hereditary alpha-1 antitrypsin deficiency. So this will lead to no alpha-1 antitrypsin in the body. And that will lead to all of this. And that will lead to emphysema. What a clinical point that you have to memorize, just write it down on some pad, that whenever a patient has alpha-1 antitrypsin deficiency, it's always going to get liver cirrhosis. Why is that? Because alpha-1 antitrypsin is being produced inside the liver cells. And due to that mutation, it's not being transported. It's just being collected and collected and collected and collected. It will further lead on to liver cirrhosis. So alpha-1 antitrypsin is always associated with liver cirrhosis. So all of this led to emphysema, destruction of the alveoli, destruction of the alveolar sacs, destruction of the alveolar valves. Now, what will be the morphology? As you can see the morphology right away. You can see the holes, you can see the elasticity gone, you can see no elasticity at all, you can see big and small holes, you can see different structures and different size of structures present here. This is a classical photo of emphysema of postmortem. This is what it looks like afterwards, destruction of alveoli and stuff. At histological slide, this is how it will be shown, that all of that is gone. All of those walls are gone. There are huge spaces. There is nothing elastic about it, not enough blood supply, and huge spaces that don't have the ability to recoil even. So what are going to be the clinical features in this patient? We know it's obstructive disease. First point you have to get in your mind, it's obstructive disease. What's going to happen? First of all, there will be hypercapnia. Why hypercapnia is happening? Because it's obstruction. Carbon dioxide levels are rising. And as it's rising, it will lead to hypercapnia. This will lead to pursed lip breathing. It's very high yield to know what pursed lip breathing is. In board exam, they ask what's pursed lip breathing. When the elastic quality of those valves are gone, there's an increased risk that those walls might collapse because there's nothing elastic about it. As the air is going away, it's giving off a pressure that may lead to that collapse, which we have been talking about since atelectasis. So what will happen is that patient which has this condition is going to compensate for it without even knowing about it, because this is what makes him feel better. As he expirates the air, that pressure is going to get the walls collapsed. He does it through pursed lips, like this way. Why does it happen? Why does he do that? It's slow process. Why does he do that? Because as he's expiring, he's doing it through perslipsing. So that perslipsing is going to give a back pressure. That back pressure, because you're not giving away all your air, you're keeping it, you're building a back pressure. That back pressure is required to keep those alveoli, those airways open. So whenever you meet a person of emphysema, you will always see him breathing like this. Then the patient will be underweight. Why is underweight? He's not getting enough oxygen. His body is not getting enough oxygen. A lot of degeneration is going on. He's losing a lot. Then come lung sound diminished. Lung sounds are diminished. Why is that happening? Because those alveoli are degenerated at many levels. You cannot hear the lung sounds. Muscle retraction. Muscle retraction will happen. Why do you think that will happen? Because those muscles were supposed to push up. Those muscles were supposed to, I told you earlier, I think, that the major instinct of alveoli is to collapse. And the major instinct of chest and muscle is to expand. When all of this is happening, in compensation of that, muscle retraction will happen. And use of accessory muscles to breathe, because those muscles are not working enough. They are actually compensating for what happened to the alveoli. They're not working enough. So we start using the accessory muscles so that we can get enough air inside our lungs that can oxygenate our body and we can keep living. So what's emphysema compensatory? This is pursed breathing actually. You're compensating for emphysema, and this is how it's shown. Look at this slide. Look at this level. All of the alveoli are not at all right. They are losing the elastic power. They're losing everything. And due to emphysema, all of this patch you can see. This is the clinical X-ray for a compensatory emphysema. In obstructive overinflation, emphysema, this is what it looks like. This is what it will look like in obstructive overinflation of emphysema. On X-ray, this will be the finding. Then comes the bullous. Bullous is actually an obstruction. Bullous is congenital malformation, a structure which is produced and keeps pushing and gives that pressure and obstructs if its size increases. You can see the bullous right here. Then comes mediastinal and interstitial emphysema. You can see all of it. You can see all the blood vessels. You can appreciate all of it and look at it. All of these structures are very important in getting to know the mediastinal emphysema. Now asthma. What is asthma? Actually, asthma is inherited in most cases, but it's inflammation of the walls of airway tract, which is reversible. It's a reversible condition in which airways are inflamed, mucus is being produced, person is unable to take air in because of all of that reaction, but it's not permanent. It's just temporary. You can reverse it, and it almost always happens due to some mediators, in the environment, or due to some mediator which is happening to you right now. We're going to talk about its types as we go further. First of all, I'm going to show you the airway tract of a normal person. This is a normal person air tract. You can see this is the whole lumen. This is the covering and the muscles, and then the alveoli. What will happen to asthmatic? In asthmatic patient, the lumen is narrow now because of that inflammation which is happening, because of those inflammatory mediators that are being released. And it will start producing, look at it, it will start producing mucus, a lot of mucus. All of these goblet cells are producing mucus. So mucus will start accumulating, and this will make it difficult for you to breathe properly. And then comes a status, then comes a problem which is very fatal, which is very life-taking, which is called status asthmaticus or asthmatic during the attack of that status asthmaticus. Now you have to differentiate here that look at these muscles. These both are relaxed muscles. But what happens inside the attack? The wall inflamed and thickened. As you already know, it happened in the same way. But these muscles are now tightened because of that attack. The muscles are tightening. And some air is trapped in the alveoli. Air can't even leave, so how come the air will come in? All of this area is overcome with the mucus. There's no way of that air to leave the alveoli, and there's no way of the outside air to come inside. So this is why it's very dangerous, it's very fatal, and all the patients that are asthmatic or have tendency to develop asthma in their lifetime, they're prescribed bronchodilators in case of emergency. Let's talk about the types of the asthma that I was talking about. What are the types of asthma? What are the basic causes of asthma? It can be non-atopic. It can be non-atopic. Non-atopic means it can be due to hypersensitivity. It can be due to anything. Then comes atopic causes. Atopic causes are those causes which are stress-induced or exercise-induced. Some people just get asthma when they're running, when they're exercising. Then comes drug-induced. There are many types of asthma which are drug-induced. Very basic type is aspirin-induced asthma. As you take in the aspirin, asthma exacerbates. Then comes occupational. There are some patients who have occupational asthma. They cannot be working in a coal mine. They cannot be working in a pneumonia environment. Pneumoconiosis will happen to them. So all of this is occupational hazard. It also includes those patients who work in the fields and get pollen. It's also occupational hazard. Although it's not a topic, but it is occupational too. So let's get on to, first of all, atopic. In atopic, it's normal bronchi. This is the airway, this is the muscle valve, and this is the mast cell. This is a normal bronchi. A large lumen, mast cells present, normal bronchi, muscles are relaxed. So mast cell is resting right now. Mast cells is resting right now. So whenever there's some pollen from outside or the patient is exercising or all of those things which we discussed about is going to happen, it's going to get reactivated. So this mast cell is resting and waiting for it to get activated. IgE is present on it. IgE is going to act on whatever comes inside because it controls basically the hypersensitivity reaction that is going to happen in most cases. So what will happen in case something will happen in case patient started exercising or other factors? The bronchi will constrict right away. Increased number of mast cells will produce. This muscle will tighten and the lumen will be narrowed and the mucus production will increase. As you can see, mucus production increased, muscle valves strengthened, and inflammatory substances are there. All those inflammatory mediators and cytokines are there to work on it. So the mast cell is activated now. What does mast cell is going to release? Histamine. When was histamine produced actually? No one knew. Let me give you a background of this. So when a person who is genetically susceptible to asthma is introduced an allergen, whatever that type may be, maybe that type is pollen, maybe that type is exercise, maybe that type is drug induced. Whenever an allergen is introduced, what is going to happen? It's going to trigger the response of Th2 cells, of CD4 plus T cells. Th2 cells will be produced, which will in turn produce three cells: interleukin 4, interleukin 5, and interleukin 10. That's how you remember it: 4, 5, 10. Interleukin 4 will let its transition go through to become the IgE cells. Interleukin 5 will go on, and eosinophil will be called. Their function is to bring in eosinophils. And what does IL-10 does? IL-10 stops the production of helper T cells 1. So in turn, they increase the production of H2T. So this is how those IgEs were produced, which present on the mast cells. So that whenever that allergen is introduced, that IgE is always ready. And those histamines are always packed. So now let's get back to the topic that when we introduced the pollen, we introduced the antigen, we introduced whatever exacerbates the asthma, mast cells get activated. What does these mast cells do? First of all, they release the histamines. They just get rid of them. They just release all of it. What does this histamine do? It does two main functions. It causes histamine induces increased permeability to the membrane, increased permeability of the blood, and it also causes histamine induced vasodilation. So now mast cells is activated. It has given off IgE and it has given off its mast cells, its histamine cells. Now what's going to happen? These, as you can see, inflammatory substances are being released, histamines. Now let's see what is going to happen in the asthmatic pathogenesis. As we talked about all of the layers and all of the cells before, these are the goblet cells which are going to produce all of the mucus. These are cilia, which the basic function of the cilia is to clear the mucus. As you can see, as the antigen has been introduced, the production of mucus has been increased to many folds. This is lamina propria. It's responsible for providing all of the structures with the blood supply. Then comes the glands and cartilages. So in asthma, you can see increased mucus production is happening here. So this will lead to asthmatic attack, and this will lead to as it's increasing the mucus amount inside the respiratory tracts. It's difficult to inspire, it's difficult to expire. Now let's get to know the pathogenesis one by one. I already told you all about it. Now we're going to go to the picture memorization thing. I hope this will help you remember it more efficiently. So as you can see, this is a pollen, which is our antigen. It's going to get into this place and start the whole process. And this is the goblet cell, and this is the mucosal lining which contains cilia. So this will start the production. This will start, T cell receptor will get attached here and Th2 will be produced. This Th2 cell will produce three basic interleukins I told you about. IL-4, first of all. Let's talk about IL-4. What was it going to do? It was going to let its transition go through to IgE cells. Now, IgE cells are produced for hypersensitivity, to control the hypersensitivity, and these are going to get deposited on the mast cells for the future use. For the next time when this antigen comes in, for the next time when a person is exposed to this antigen again, this will release its antibodies, IgE antibodies, and they will take care of the hypersensitivity reaction. Then what happened to IL-5? I told you, this will be wholly committed for the eosinophil recruitment. And then release of granules and mediators, those inflammatory mediators. And one thing they haven't told about here is IL-10. Somewhere along here, IL-10 happens. This IL-10 stops the production of Th1 helper cells, so that Th2 helper cells, the amount of Th2 helper cells will increase and increase, and all of this process will be keep happening. So we talked about it already. So this is what happened. These are the antigens coming in, all in, and then vagal afferent nerve is getting the impulse, and this led to a lot of mucus formation. As you can see, a lot of mucus is here, and this will lead to the recruitment of eosinophil, increased vascular permeability and edema due to what I told you that histamine. Due to the histamine, there's increased vascular permeability and edema, and then mast cells are going to act on it. These mast cells are the one which release those histamines, which led to increased vascular permeability and edema. So these mast cells are going to increase this edematous phase, and this all happened inside minutes. Antigen came in. What happened? It sensitized it. What happened? Mast cells took it. Increased vascular permeability happened. Eosinophils happened. Th2 was there, and smooth muscle edema happened. This happened in a minute. What will happen in a long time? A large amount of mucus been produced. Major basic protein eosinophil ketonic proteins are produced. Look at it. All of these structures are right now here: basophil, eosinophil, neutrophil, Th2 cells. All of these are produced because they are taking care of that. They are here because of those inflammatory mediators, and the white cells are being called, and the eosinophils being called by IL-5. All of this happened within days or in a longer time. Now let's discuss how it will be seen on a slide, on a cross section here. Let's go one by one. You can see the amount of mucus right now. This was right here in the start, and now it has exceeded all the expectations. Mucus is too much for air to even pass through it. Then the goblet cells which are secreting the mucus, they are inflamed, they're high. Then eosinophils are present because of IL-5 cells. Then there's basement membrane, which is exactly the same. And in this level, you can see the macrophages. You can see the vasodilated blood vessels. You can see the smooth muscle, which is hypertrophied, which is increased in size. And then gland, the structure of the gland has dramatically increased because of increased secretion of mucus. Then there are mast cells present, which are playing a major role in this whole reaction, which are releasing the histamines, which are releasing the IgE. Then there is eosinophils present, which came due to the IL-5. And then there are lymphocytes present, and then neutrophils present because of all that infection going through. So what will be asthma on morphology? What will be the morphology of an asthmatic patient, a lung of an asthmatic patient? This is how it will look like. You can just admire the whole thing right here, that it's inflated, the blood vessels, it's a lost its elastic power. You can see right here that this is lamina and this is stuff, and you can see those walls which are not even working, which are whitish areas. Then comes the clinical features of asthma. What will the clinical features of asthma? Every one of us has at least seen 2 to 3 patients of asthma in our life. Many of us have them in the family. So what will happen? Cough will happen, chest pain will happen, because he's unable to even breathe. There's a lot of pain, there's a lot of sputum inside the body, there's a lot of sputum inside the chest. There's a labored activity of breathing that will lead to cough, it will lead to chest pain. And allergies will happen. Mostly in 90% of the patients, these patients have allergies to pollen or some other substances which they might not even know of. These patients always feel tired because they're not getting enough oxygen all the time. Their brain is not getting enough oxygen all the time. Their muscles are fatigued because of that labored breathing. Shortness of breath because of all of this that's happening, that labored breathing, that everything that going through, that air is not being enough for the body. Then breathing difficulty. It's difficult to breathe because of that mucus production, because of that inflammation that's present inside the walls. So it's very difficult to breathe even. Now let's get to the COPD, chronic obstructive pulmonary disease. What does it stand for? Chronic obstructive pulmonary disease. When do we say it's chronic? When a patient gets the disease for 3 months in a year, for consecutive 2 years, we call it a chronic disease, a chronic respiratory disease. What will happen in COPD patients? Airway remodeling and fibrosis will happen. You can see it right here. Remodeling is happening and many structures and many layers will undergo fibrosis. Airway obstruction will start happening because that lumen is now narrow. Then airway obstruction is started. Then alveolar valve and destruction and loss of elasticity will happen. Because of what? Because of all these diseases we have mentioned above. Because of that, elasticity is going. Because of elasticity is going, those alveoli are not even functional at their best. So they are not even contributing in the exchange of the gases that's happening inside the body. Alveoli will hyperinflate. Why? Because it does not have any elastic power. It's not like they will take the air in, then push the air out. They are just open. They are just like shopping bags. They're hyperinflated now. There's no recoiling power at all. There's no elasticity at all. Smooth muscle contraction will happen because of all of these processes. Smooth muscle will start contracting and the lumen will start getting narrower and narrower with the time. So what's the pathogenesis? First of all, I already told you, whenever the word pathogenesis of a disease in a respiratory module will come, smoking will be the major cause of it. Smoking will be the major contributor and etiological factor in this scenario. First of all, it will lead to lung inflammation. Host factor implying mechanism you already know. We discussed how a smoke can affect the whole body and how it will lead to the inflammation of the lung. All of that process will happen, and this will lead to pathological changes of COPD that we already talked about. That narrowing will happen, smooth muscle will tighten up, and all of elasticity will be lost. There will be hyperinflation. All of that will happen. Now, when the lung inflammation will happen, there will be oxidative stress, which will impair or repair mechanisms followed, which will be followed by impair and repair mechanisms. But this is also somehow affected by anti-protease activity. On the other hand, there's oxidative stress, which will lead to pathological changes of COPD. In this, antioxidants play a major role. So two things play a major role in this: antioxidants and anti-protease activity. So what are the stages of COPD? How do we define the stages of COPD? How do we define at which stage the person is right now? So there's a scale of mild, moderate, and severe, and very severe. So what's the moderate is going to be? In moderate, so we are going to decide whether the patient is mild, moderate, severe, and very severe on the basis of pulmonary function tests that we did in the start of this lecture. If you've forgotten about them, go back and revise them so that you can get the idea that why they're mild, why they're moderate, why they're severe, why they're very severe. First of all, in mild patient, FEV1 over FVC ratio will decrease, that will be down than 70%. What's the normal value? 80%. So it will be less than 70%. FEV1 will be more than 80% predicted. I hope you got the point. I told you FEV1 will not be that much affected, but FVC majorly affected. What will happen to moderate? FEV1 over FVC is down than 70%, and in this 50% of predicted is less than FEV1 of less than 80% of predicted. So we thought in mild form it was more than 80% or equal to 80%. Now FEV1 is down to 80% of predicted or less than that. In severe form, FEV1 over FVC ratio will decrease than 70%, which is 30% of predicted, which is either less than or equal to FEV1 of less than 50% of predicted. And in the very severe form, it's less than 70%, but FEV1 is less than 30% predicted, or FEV1 is less than 50% predicted plus respiratory failure. Respiratory failure will be a major part in very severe syndrome. So we have to decide all of these on the basis of pulmonary function tests. And we all discuss them in detail, so you might know the values by now. These are the function and symptoms of breathlessness. In mild form, there will be no breathlessness or even mild breathlessness on exertion or something. In moderate, whenever you'll exert, there will be breathlessness. In severe, on minimal exertion, like even you're dressing up, you will be breathless at the end of the dressing. And in very severe form, you will be breathless all the time. Even when you're sitting, you're just breathless. So what will be the morphology of COPD? As you can see, a lot of cells here that are present, which contain all of those macrophages, all of those leukocytes, all of those mast cells, all of those cells which we talked about in detail, all of them will be present here. And all look at the size of these alveoli. Size of the alveoli have increased. They are hyperinflated now. They're not that elastic now. They don't have that recoil power. So what are going to be the clinical features of it? The clinical features of it are going to be pursed lip breathing. I already told you about pursed lip breathing, that this is a way in which a patient provides himself with a pressure which is called backflow pressure. And that's how they keep the alveoli open. Then comes central cyanosis, because alveoli are destroyed mostly. There's no exchange happening in some places, and some exchange is happening at some places, so there will be cyanosis. Blood is not completely oxygenated. And then prolonged expiration, because you're doing that pursed lip thing. It will take a lot of time for you to breathe out that air while taking care of your walls of respiratory epitheliums, that they don't collapse. Reduced cricosternal distance. Why will that happen? Because of muscles. They're compensating for that alveolar thing. I told you earlier about that. What's the major instinct of muscles? They're going to pull up. They're going to get distended. Intercostal indrawing during inspiration. This will happen because you want to use them accessory muscles so much. Cardiac apex not palpable, loss of cardiac dullness on percussion. Why is that happening? Because it's dull. Air is not in there. It's due to its hyperinflation and no elasticity. There will be dullness on percussion. Inward movement of lower lips on inspiration, low flat diaphragm. Then there's heart sound is loudest at epigastrium, because that's the only place you can hear the heart sound at, because the dullness of the lungs, you cannot even hear the sound of the heart. Then auscultation reduced breathing sound plus wheeze. Auscultation reduced breathing sounds mean due to the dullness you cannot even listen to those sounds, those breathing sounds on even auscultation. And use of accessory muscles, I already told you, accessory muscles are used in thirst to compensate for that loss that we are having right now in this patient, in order to get the maximum amount of air in so that a person can inspire and expire at the normal value. A person can oxygenate his whole body for once at least. Now on to our last topic that we were going to discuss is overlap between chronic lung diseases. We pretty much went through all of those lung diseases, so we know what's the overlap between all of them. Let's discuss. In chronic disease, small airway disease contains emphysema, in which alveolar valve was destructed and overinflation was happening. In asthma, it was reversible obstruction. And in chronic bronchitis, was productive cough and airway inflammation. So all of these diseases contribute a little to COPD. All these happenings have been happening amongst pretty much all of them. So bronchial hyperresponsiveness triggered by allergens and infections, etc., are found in them. So in this lecture, we learned about all the differences between obstructive and restrictive pulmonary disease. You might want to remember that. Afterwards, we studied emphysema, asthma, COPD, and then their relationships between them. In order to want to see more lectures, please watch sqadia.com. Thank you so much.